Hi, I'm Giulia Gibiino and I work in Forlì Cesena hospitals in Italy. I'm here with my colleague, Dr. Cecilia Binda.
Hello.
And we are going to comment our recent thick and thin study. First of all, I would like to thank all the co-authors and the study group, and a special thanks also to Endoscopy for choosing our manuscript. As you know, the colorectal full thickness resection is considered today a procedure of proven efficacy and safety. However, technical issues or dysfunctions are reported and described. So we performed a multi-center study in order to quantify and classify all the technical dysfunction with the dedicated device EFTR. We invited 17 Italian centers with experience in resection technique and in Ovesco device. They shared and classified all the consecutive failures prospectively collected during the last 5 years. The primary outcome was to define the technical failure rate and to classify it. And the secondary outcomes included the management, the clinical success, and the complications in this study population.
So over the study period, more than 700 EFTR procedures has been performed among all the centers involved. And in this study period, the technical failure reached the 10% in our study. And while evaluating which has been probably the technical issues encountered during the procedure, the snare cutting was the most frequent device dysfunction, being classified as type 1, followed by clip misdeployment, so the type 2, and the cup misplacement, the type 3. Interesting and fortunately, in most of the cases in which a stent dysfunction occurred, that was not a link for to a complication for the patients that experience at least an adverse event in 1/3 of the cases. And in the majority of the cases, this complication was mild in severity. And while in case of technical issues with the device, in most of the cases, an endoscopic treatment was feasible, being rescue EMR performed in more than half of the patient, leading to achieve an unblock and R0 resection in most of the cases. While considering the volume center, we can say that complications, the rate of failure, and the rescue endoscopic therapy were similar between both low and high volume centers.
So I think that we can share some comments and considerations. The first is about the importance of definitions, and we shared with all the participants the technical feasibility prior to proceed to EFTR and to observe this kind of dysfunction. And we discussed about this point with the reviewers. Despite the indication, we observed that EFTR with EFTRD is a challenging technique with a not negligible rate of dysfunction. So even if the complications were very few, it is very important to have experience also in a rescue resection technique. And also it is mandatory to have a multidisciplinary management and approach in this setting.
So this is the first attempt of a classification of the device dysfunction that we hope may be useful for future standardization of the technique, of course, but above all, to help patients and lesion selection and to define which is the best and homogeneous training among all the European centers that adopt this kind of procedure.
So thank you very much and bye.
Thank you. Bye-bye.